this safety chamber, and this safety chamber is what is blowing air. It was initially carbon dioxide, then changed to helium because of decreased turbulence. This was a side-to-side anastomosis of a 30 French Dacron graft that went here. Then you had two balloons, a more distal one and a proximal one, okay? And so he had three groups of patients. Group A was the patients that had unrelenting angina or they were already in cardiogenic shock before revascularization, and he started them on pump and showed that of those 17 patients, 65% survived. Group B showed the patients that could not be weaned from cardiopulmonary bypass, and showed that 60% of them were discharged from the hospital and were eventually weaned. And then the Group C patients were the patients that probably should have been Group B, but they ended up in the recovery room and then going to cardiogenic shock. And obviously, you can see their survival was worse. And he had this hypothesis that we should start the intra-aortic balloon pump and revascularization early, which is now, it seems like a paradigm shift. This is also from his book that may kind of show what they were dealing with in this day and age. So here's this graph, the safety chamber, the balloon pump, which is pumping air in during diastole and suctioning during systole. The EKG and the arterial pressure waveform, which were responsible for triggering. Now, I'm going to show you a video in a little bit that shows how antiquated the initial Datascope machine was. You can imagine if you had a ventricular arrhythmia, how it may throw off the machine. This is his book, Mechanical Support of the Failing Heart and Lungs. And what is this? I'm going to get to that in a second. So this is a pulsatile assist device. This was his idea, and it was his invention that he was supposed to get money from selling it to Datascope, because right here, look, this is his patent. Well, he, wasn't obviously a businessman. This is part of the reason why I went to business school. The university, as well as some people who were overlooking him, Dr. Mom, which is a telling name, actually told him, you should go ahead and kind of sell your rights for cheap because of the notoriety that you'll achieve, but I want to talk about this device. So this pulsatile assist device goes in series with the heart-lung machine. And the idea was that the heart-lung machine with these rollers was continuous blood flow. It did not provide pulsatile blood flow. Some initial studies showed they had decreased coronary sinus lactate, increased urinary output, better outcomes when the patients had pulsatile blood flow because it was more physiologic. So all the other machines in the past that tried to do this caused the same thing that Harkin caused. They caused hemolysis. So he said, well, I'm going to use this polyfluoroethylene balloon, the same as the balloon pump, in this safety chamber, and it's not going to cause hemolysis, and it will seamlessly, in series, without any additional thing, add the option of pulsation as well as counterpulsation, because he said if you just clamp this and then have this operate during diastole and systole instead of the other way around while in the heart-lung machine, prior to them going on bypass and opening up the chest, you can reperfuse their coronaries and try to decrease the ischemia time. So this was his invention, and this is that device. So the idea was that either A, they could hook it up to the heart-lung machine, and it goes right here, and then it goes into the coronary ostia, or this kind of goes back to what Harkin was talking about, minus the hemolysis, just putting it into the axillary artery or putting it into a femoral artery and counterpulse. And then this is the entire heart-lung machine with pulsatile assist device in tandem. One of the things that he did with his math major is this endocardial viability ratio. He published this paper along with Dr. Phillips, and initially there was a machine with Datascope, the initial balloon pump, that tried to look at this. Now, I alluded to this earlier, this tension time index and the diastolic pressure time and the left atrial pressure. So normally, if you have a heart that's really working to pump, your TTI is high. This is your demand, and then your supply is pretty low. Well, if you counterpulse them, then you have high supply and then low demand. So they looked at this ratio that was calculated here. So DPTI over TTI. You want it over 1. You want your supply to be greater than demand. So he did this with his patients that he put on pump and showed that the patients that he put on pump earlier had better outcomes and better endocardial viability ratios. They don't use this anymore, but I thought it was pretty ingenious at the time to show that, yes, here's a quantitative reason as to why what I'm trying to do works. So this is when he became famous. This is his paper that showed, hey, we can do this at the bedside. You don't need a cardiothoracic surgeon. And cardiologists started to do this at the bedside. And I thought this was quite telling. Use of percutaneous intra-aortic balloon pumping should broaden the application of balloon pumping in the both medical and surgical setting. I think it has. You walk into our CCU, you're going to see patients on this. And they're using the Seldinger technique that he described. Seldinger first used the technique in 1953, and then PTCA first started happening in the 60s and then became popular in the late 70s. So, I mean, he was right during this time. So the way that this worked was you manually had to wrap this balloon around the wire, dip it in saline, and be very gentle in inserting it. They had some iterations of this that became all assembled in one. I want to have time to kind of give you a brief story about him that'll be pretty funny, but we use the intra-aortic balloon pump in unstable angina, cardiogenic shock, high-risk cardiac surgery, and high-risk PCI, obviously. Here, I'll get to that in a second. So, all right, so David was a really interesting man. One of the things that he loved more than anything was fishing. And he had a lot of money because it was the 80s, it was the heyday of medicine, and he was performing surgery. So he had himself a 48-foot Hatteras that he kept in Key West. And this is Cuba. This is Cuba in the early 1990s. There was a trade embargo. You can't go there. Well, not if you're David Bregman. You can't. So apparently he had a friend in the State Department who has some connections with South America, a company that made some of the parts of his balloon pump to allow him to go to Cuba and teach the Cuban doctors how to use the balloon pump and indications. He took his son Jay and went to Cuba. One of the stories that he told me was that he was taken at 11 o'clock at night. They knocked on the door for his boat and said, "Come with us." And he didn't know where he was going. And it was actually to see Fidel Castro. So he sat down, had whiskey and a Cuban cigar with this man, Fidel Castro. And he said he was a really nice guy. And he always had these weird communist attitudes that I never really understood. And he had this thing with Hemingway, who also loved Cuba. Last story that I want to tell you before getting into where the balloon pump is today is, so twice in medical school I was approached by professors and asked, really old guys, and asked, "Are you related to David Bregman?" So first time was during my third year of medical school. This cavalier thoracic surgeon who was a trauma surgeon said, "Is that your uncle?" And I said, "Yes." He's like, "Wow, I read all of his papers." And he said, "I'm going to flunk you unless we FaceTime with your uncle." So we FaceTime with my uncle. He then asked me later, "Who the hell is that guy?" And then the other time was a very old cardiothoracic surgeon was talking to us in our fourth year about medical ethics. And I asked him because he was practicing in New York, if he knew my uncle. I gave him my uncle's phone number and they talked that night for 2 hours. And it was stuff like that that, you know, made me just be so proud to be a doctor, to be a Bregman, and to, you know, to be even associated with someone who did so much in their career, even at an early age. He was really ahead of his time. I want to show you this YouTube video so you can actually see him. Now, if you don't know this, because I didn't, and Dr. Google let me know, Vanderbilt has a TV archive you can get like literally anything from. So this is from September of 1980 when he was on the news, and apparently he was on the news like an hour segment that I couldn't find. But here's a 1 minute segment. Oh no. Oh. I can. I don't think it's working. Sir. So. I want that mustache. All right, that's fine. So we can just watch it. He comes and talks. So this is 1980. This was a year after his paper on the percutaneous technique came out. This was that initial that was the initial machine from Datascope, and they're showing that the Seldinger technique and saying, look at how amazing this is that doctors can do this at the bedside and save a dying heart. This is an animal simulation that they showed. So this was the diagram that I showed you. Here he is. Yeah, John. And I love how this guy's name is Bregman. No relation. But I showed this to some people in my family, and they thought it was amazing. Back one slide. Okay, this is actually current information that I'll just go over real quick. So this is new insights as to why we use the intra-aortic balloon pump today, because you probably have seen we have Impella, and it's 2.5 liters per minute or 5 liters per minute, as opposed to the McKeck machine, the intra-aortic balloon pump that gives 0.5 to 1 liter per minute. So this first study was the PROTECT 2 trial that was published in Circulation with the primary investigator, Dr. O'Neill at University of Miami, that showed a 21% reduction in major adverse events at 90 days with the use of Impella versus intra-aortic balloon pump, and this was in patients with that needed hemodynamic support for high-risk PCI, and that was described as an EF of less than 35% with an unprotected left main, or an EF less than 30% multi-vessel disease. So it's, you know, that was a decent sized trial, but there were some issues with it in terms of the size, and it had to be stopped early. And then this is a New England Journal trial. This is the IABP SHOCK 2 trial. This was performed in 2014. This was a randomized prospective multi-center trial with 600 patients with cardiogenic shock that complicated acute MI. They were randomized to intra-aortic balloon pump versus no balloon pump and maximal medical therapy with either pressors, inotropes, or both. They all got early PCI or best medical therapy. The primary endpoint was 30-day all-cause mortality. They found no significant difference in that primary endpoint, and no difference in length of time in the ICU, serum lactate, dose and duration of catecholamine therapy, or renal function.
This study actually downgraded the use of the IABP in STEMI patients from a 1C recommendation to a 2B, but there were a lot of problems with this trial, including the timing of IABP